The debate is whether children should be allowed to be living donors. Okay, we're running a little bit late, so I'm going to try and restrict our speakers to the length of time they speak. Dr. Marks, that's going to be very difficult, but I've got some backup in the room. So we're going to get 10 minutes from Kristof, 10 minutes from Steve, and then we're going to throw it open to the floor for people to make points, ask questions, and then 5 minutes from each speaker. And before we start, can I just ask how many of you, show of hands, agree that children should be allowed to be living donors? Just show of hands. Just not routinely, but whether or not you would consider in some circumstances whether children could be living donors. 1, 2, 3, 4, 5. Okay, so Kristof, not going to be easy.
I'm the minority position. Okay. So good morning and greetings from Belgium. I'm sorry I couldn't attend the meeting due to the medical reasons. So should children be accepted as living donors? When asking this question to transplant centers in both Europe and the US, more than 9 in 10 centers accordingly states that they did not, or that they consider age less than 18 years as an absolute contraindication to becoming a live donor. Nevertheless, if you look at the past 40, 50 years, there have been reports in the literature of about, let's say, 60 to 70 cases of live donation by minors, usually in the US. Let's take a more close look at the European map for now, and all the countries that are colored in gray are countries that have an absolute prohibition of live donation by minors. So the law has a prohibition of donating organs. Countries colored in yellow are countries that exceptionally allow minors to be live donors under strict safeguards. And if you look at these countries, and they are Luxembourg, Norway, Sweden, and the UK, you see that the conditions they apply for minors to be donors are considerably more strict than those for adults. Between these 5 countries, there is maybe a concordance. For instance, in Belgium and Luxembourg, the state that the recipient must be a sibling of the donor. In Belgium, Luxembourg, the donor must be at least 12 years old. Most countries state that the donor must provide consent, and usually also that the parents must provide consent. And in most of the countries that allow live donation, also there should be an approval by an independent committee or a court, usually, or a governmental agency. Now, so as you can see, there is a strong moral intuition also in the law that minors should preferably not be considered as potential live donors. But there are ways of implementing this. Most countries, they opt for an absolute prohibition, and they do not give any opportunities or circumstances in which minors can be donors. But in other countries like Sweden and Norway, as we saw, they also have a strong feeling against it, but they do apply, they consider it more like a relative contraindication. So they have exceptional circumstances where minors can serve as donors. And what I would like to do with you is briefly run through a few of these safeguards that apply, and maybe it might be more full and more ethically desirable, and what could be potential safeguards that we could implement. Potential safeguards, they do correspond to the main concerns that we have, the main ethical concerns that we have regarding live donation by minors. And I think these main concerns are situated to 4 areas. I think they have to do with the decision-making capacity of minors, the parental or the restrictions to parental authorization, the fact that it may not be in the best interest of a minor to serve as a live donor, and that it may be a disproportionate measure to allow a minor to be a live donor. Let's look at the minor's decision-making capacity. So I think a first reason, strong reason why we have, or why some countries prefer an absolute age limit of 18 years is because they presume that if those who are 18 years of age or less than 18 years of age or do not have the maturity to consent to the procedure, or either not cognitively because they cannot understand relevant information and make a decision, or not psychosocially because in the whole transition from childhood to adulthood. Of course, we know that every legal age is in a certain sense arbitrary. And for instance, in most countries, the age is 18. But if you look at Scotland, for instance, the age of majority is 16. In some Canadian provinces, for instance, the age of majority is 19 or even 20 years old. So there is when it comes to maturity, and you can have missings at both ends. You can have, of course, situations in which a young 20-year-old will not be sufficiently mature to make the decision, but you could also think of a situation where, for instance, a 14 or 15-year-old may already have the maturity to understand all and make his decision, because these children, of course, live in a family where there is a child with a chronic illness, for instance, and they know very well what the impact on the family is and what the treatment options can be, and maybe they may be able to make their own decisions. But if you look at laws regarding healthcare in many European countries, we do allow minors to make lawful healthcare decisions about therapeutic decisions based on the case-by-case analysis, where it is the treating physician who will case-by-case analyze the maturity of the minor. And we could maybe think of a similar system for live donation so where we do allow competent adults to make this decision. But I think this requires more time. I think it requires that we have a longer procedure, a longer decision-making process involving also health professionals with specific expertise in, for instance, childhood psychology. Second safeguard may have to do with parental authorization. So the concern could be that parents are not really good decision makers for young children to be live donors because they have a conflict of interest, because it's maybe one of their children may be the prospective recipient and the other may be potential donor. It could be difficult for them to make this decision because they've experienced this conflict of interest. But a potential safeguard here, it has been proposed as well by the American Association of Pediatrics, is maybe you should also aim for not only for a decision by the minor, but for a family decision. So next to seeing the minor individually to assess his competence, it might be a good idea to also have family consultations and look what the family dynamics is. And if there is a shared decision-making process involving both parents and children agreeing with it, it might be in some circumstances appropriate to go ahead. Counseling process might also be able to safeguard authorized donation by an independent body, such as an independent hospital ethics committee to look at it, or an independent advocate of the donor who really takes into account the best interests of the minor to authorize the donation. This brings us to the following point relating to the best interest. So one reason why we don't allow minors to be live donors is because we assume it's not in their best interest of doing so. And we have a lot of concern about the risks, both the operative risks, but also especially the long-term health risks of living with one kidney. We know in general that the long-term medical outcomes of the risk of having end-stage renal disease is more or less similar to the general population. But of course, there is a selection because they should be healthier screened, so they should be healthier than the general population, have better outcomes. And there is quite a lot of concern about psychological risk of donating at a young age, which usually depend on the outcome of. But still, you could say maybe we could have tried to get there is a favorable balance between anticipated risks and benefits. For instance, we could try to limit the risk by not allowing minors to donate in case when there is a genetic disease involved, or cases like polycystic kidneys, where the disease might still occur in the young donor after several years later. I also think a potential safeguard might be that there is a strong emotional bond with the recipient. I think we could allow it to donate a minor to a child or to a sibling, but not to the parents. And they would need probably a longer and a more intensified both medical but also psychosocial follow-up. I think the final category of safeguards has to do with the proportionality. I think one of the main concerns about accepting minors is that minors could be accepted as donors when there is actually no desperate medical need for it, or when we have sufficient alternative treatments available, or when other people of the family would also be acting as living donors, and then it might lead to a kind of exploitation of minors. And others might use it as an argument not to step forward as donors. So I think it's really necessary in these cases to more carefully, even than you would with an older donor, explore whether there are in these family discussions, explore whether there are other potential live donors, and that the operation has a reasonable probability of success for the recipient as well. So, taking all safeguards together, that maybe absolute prohibition, as we see in most European countries, may be too strict, and take an alternative approach where we would exceptionally allow minors to be donors if strict safeguarding mechanisms should be put in place. I said that the recipient must be a sibling or known child, not a parent, because the risk of pressure might be too high. There should be a scrutinized and longer evaluation of motivation and maturity of the minor to be really sure that the minor has realistic expectations about the outcome, has keen motivations, and the decision is not based on impulsivity. There is a more careful deliberation of alternative options, a longer transplant counseling and follow-up. I think parents and recipients should be strongly involved in the decision-making for these family counselings, and I also think there should be some way of an independent decision as well, maybe preferably by a hospital ethics committee. Thank you very much.
Kristof, thank you. You were just cutting out a little bit. I'm not sure whether it's your microphone when you lean back or bandwidth when you're moving around or both. So maybe when you come back, if you could just stay still next to the microphone. Okay, so Steve, we've got a 16-year-old who's got a twin who's dying of renal failure with precarious vascular access. Why shouldn't their twin be allowed to donate to them?
Thank you very much indeed for the kind introduction, Nizam, and for Kristof. We're waiting to go back to normal. So I've been toyed with, should children not be allowed to be living donors? And Kristof, if you're still there, we're going to have a bit of a fight on our hands here. And this has got nothing to do with last night. I don't know if you saw about Tyson Fury having a fight. So Nizam is our Mexican adjudicator who Tyson said he should no longer be doing his job. Don't worry, I'm not going to say you're not going to be a transplant surgeon. But Kristof, the fight is on. But actually, I've won. Because the question is, should children not be allowed to be living donors? So if you were asking the question, should they be allowed? Then you're asking the question about them. So of course, I've got to be the winner. Because the question you should be asking is, should children not be living donors themselves? Should they be able to make that decision? So I'm going to consider the debate on different aspects, because I think in transplantation, technology defines what can be done, ethic debates what should be done, but we've got the law, and we've just heard that from Kristof, that decrees what must and must not be done. So the ethics that go back in time really been described many times about beneficence, non-maleficence, where you don't do any harm, respect for autonomy, and justice. And yes, you can all be sitting there saying we've got all these people who are needing a transplant and we need to do what we can, but there are so many other options in 2018. So the first question is, would you be a living donor? Now, it might be simple. You might say yes or no. Nizam might say yes, but no to me. So maybe there might be a maybe. You'll have some caveats on what you're going to say. But it may not just be for you. And Anita and Isabel, who deal with this every day, meet lots of potential donors who don't come through. So the first thing is, in medicine, primum non nocere, this transplantation and donor nephrectomies is one of the organs where you're doing something to somebody who's otherwise healthy, who you're potentially making them unwell. So we know living donation is great. It's a tool in overcoming our shortage. We have other methods. We've got the pooled sharing scheme, the UK National Living Donor Sharing Scheme. But what we want to do, and I agree, is do preemptive transplantation, but we should not be using children as donors. So you've seen this slide. We just submitted this for publication. But yes, living donor transplantation is much better. The outcomes are out there, but we should not be doing this with using living donors, and especially when they're children. So why do you decide to donate? Why does Anita and Isabel, what is it? Is it compelled altruism? They get people who wake up one morning that want to donate the kidney. Well, children aren't allowed to do that, surely. And I come from Scotland, and in fact, do you know that in Scotland, at the age of 12, you can go on the deceased donor, so you can say that you're wanting to be a donor without your parents' consent. So we'll talk about that in a minute. So the problem is that there are complications to being a donor, and they are both physical and psychological, as well as on a social level, many others. But there actually is long-term. You can die from undergoing the operation, and there can be a short-term, long-term morbidity, and also a risk of end-stage kidney disease. And these are just not acceptable for children, and we should not be making the decision on their behalf. 15 love, if you're into tennis. So let's go back a little bit. It's a very busy slide, but what do we actually mean by child? Nobody can actually define what a child is. But if we say, put it all together, it's a young individual who's under the legal age of majority, is a natural offspring of another. The answer is, can they make their own decision? Kristof has even said they can't. And if you look at the word donor and what it actually means to donate, it also has to be compared to being a minor making a donor. So, Kristof, if you're still there, this is from you. Living donation by minors violates the general principle that minors should not undergo non-therapeutic interventions that involve greater than minimal risk. I agree with you. And there I was 12 years ago, quoting what the BMA states and still states, it is not appropriate for live non-autonomous donors, minors, to donate non-regenerative tissues or organs because, of course, we do use their bone marrows very frequently in pediatric practice. 30 love, if you're into tennis. So let's talk about death and dying. The mortality risk of donation, depending on where you look, is anywhere between 0.03 and 2%. So it can be up to 1 in 500 that is quoted in the literature. And let me just show you that you have a 1 in 10,000 chance of dying as a child in this age group. So it's a huge increase. May not be so big if you're in your 50s and 60s and 70s. But doctors are increasingly often accepting higher risk in living donor transplantation. This is just one that I managed to get from the internet of a drastic case. And of course, there have been cases in the UK as well. So what do we lie awake at night worrying about? High blood pressure, proteinuria, and chronic kidney disease, don't we? That's what nephrologists do day in, day out. But for transplantation, we're wanting how long is the kidney going to last? What are the complications? But actually, what are the risks for the donors? The risks that we lie awake at night worrying with our patients. Do you want children to develop hypertension, proteinuria? What's actually the long-term risk for a child with chronic kidney disease and end-stage kidney disease? But do we know the cardiovascular risk by removing a huge nephron mass? We know in living donation your creatinine goes up. Is that really a benign phenomenon? If you look at the long-term risks of death, number one is high blood pressure. Hypertension is a well-known complication. So if we look at different scenarios, and we don't have time to go through this, but basically, if you look at a 20-year-old, for every 10,000 living donors followed for 60 years, 1 in 50 will develop end-stage kidney disease. And that's excluding that we know what the number would be, which would be higher for a 10-year-old potential donor. We don't have time to go through all the papers and the risks, but let me just show you that the risks of developing end-stage kidney disease as a live donor compared to a non-donor population is huge. And this has been shown in 3 different publications looking at different races because, of course, it is increased in Afro-Caribbean populations in the BAMI group. And then it just show you this huge increase that you can see in the African population. So compared with a matched cohort of healthy non-donors, kidney donors had an increased risk of end-stage kidney disease. This has been showed in other groups, and again, you need long-term data, which we're not going to get for children for about another 20, 30 years. Kristof showed you the data. The first child that was used in America was a 12-year-old child with trisomy 21. Do you think he actually could answer his parents what he wanted to do? So we have to understand what obligation is and what duty is. Children have a sense of duty to do what is right, and it's the parents who's going to tell them what that duty is. Coercion happens within families that go through living donation. We know this, and in pediatric practice, it is going to be worse. I'm going to end with a quotation because I couldn't have faced my parents if I had refused. I have never liked my sister very much, but once the request was made, it was impossible to refuse, sort of family and moral duty. I really wish the question of live donation had never come up. I felt a bit like a fish on a hook. What do you think about that? That wasn't from a child. That was from an adult in their 30s. We know there's a lot to consider in living donation, but children should not be donors.
Thank you. Okay, I don't know if we can bring Kristof up on the screen so we can see him.
Yes.
Okay, so it's open to the floor for the next 10 minutes or so. Who would like to ask a question, make a point, argue with either of our speakers? Yes.
We use the term child. What is a child? At what point is a child an adult? In terms of understanding risk, you're not an adult till you're 25. So we're a long way adrift from the definition that's been used of a child here.
So I think I showed, just before you came in, Nigel, actual definitions of what a child is. And you're right, that's the problem. It's disagreed in the literature. It's disagreed by lawyers. I don't know if you were there when I said you can actually go on the organ donor register as a 12-year-old in Scotland, where you can't obviously do that in England and Wales. And I think it's a very good question, because we know if you do MRI scans, the children who become young adults, there isn't actually full maturation until you're into your 20s. And we all know that we accepted risks when we were younger that we potentially wouldn't. And the age of maturity varies, as we know in our transition work, from 14, 16, 18, even 20s and 30s. So I agree with you, it's a huge issue.
I think the issue is that until you're 25, your decisions about taking risk depends on the environment within which you're taking that decision. So if you're in a medical environment surrounded by people where they're encouraging you to donate, you'll take inappropriate risk. And that's my concern here, is actually the level at which we take donors, I think, is far too low anyway.
Okay, thank you. Kristof, can you maybe put yourself on screen? We can see your slides at the moment. We're only seeing a small version of you.
Better?
No, we can see a big version of us now. Still see a small version of you. While you're doing that, we have a child in Great Ormond Street at the moment whose dialysis access is incredible. That's good, Kristof. Whose dialysis access is very precarious. Who has no living donors. If they had a 15-year-old sibling who said, I understand the risks and I want to donate, should they be able to donate?
No, I don't think they should be allowed to donate. I don't think they're under pressure. They're under total pressure, and it's not their responsibility. Their sibling's sick. They should be allowed to live their life with 2 kidneys until perhaps they're 25. I agree with the previous gentleman about the age. Maybe we should be putting it up, not down.
Sorry, we've got a working mic over there. The Dr. Marks.
I think you've got to speak into it really loudly.
What age then would you accept? 1 second, Joe. Sorry.
I think Isabel and I agree in terms of the age. We have seen in our post-donor follow-up clinic the young adults who've donated, who years later say to us, I wish I'd never done that, where the gravity of their decision suddenly hits them, and then they need psychological support. They're much older, they have emotional intelligence. So this is what we're seeing years later in post-donations, as we both, as living donor coordinators, agree.
Thanks. Johnny, just growl into it like Barry White.
So, Steve, what age would you accept your living donor, the youngest age you'd accept, given what you've just said?
So we have discussions about this within the team. Maria and Jen are here, and I think in some respects we sometimes become a little bit parental in our views of young living donors, and part of it actually depends on the family dynamics, but also, and you can bring in a little bit of a sexist issue, is that we generally tend to think of women as being living donors, thinking of them in their future fertility and going through pregnancies and having children, and there being potentially an increased familial risk of end-stage kidney disease, but also increased risks of preeclampsia during pregnancy, for example, on having a solitary kidney. So we generally say in our 20s. But sometimes it will depend on what are the reasons within the family, for example, that the parents aren't going to be living donors. Is it the fact that they've medically failed, or is it actually, they say psychologically they're not ready? And we've had one parent who told his wife that he couldn't be a living donor because that's what Great Ormond Street said, and it wasn't until the child was about to die that we were able to expedite a 3-week living donor assessment with a full psychiatric assessment at Guy's Hospital to check he really wanted to donate for the right reasons. So I think it's very important.
That was a very nice talk. You did mention the presentation that 3 donors in the UK have been paediatric donors. Do you know anything about the age of those donors in question? Were they 16 years, 18 years, and a little bit regarding the background and the long-term outcomes?
Kristof, do you want to answer that, or do you want me to? Did you hear?
No, the connection is not very well. Can you repeat that,
Yeah,
please?
so he was asking whether, do you know about the information of the pediatric living donors in the literature? So specifically the UK, you know the three, or do you,
3 cases. There were 3 cases in the UK. I remember they were in the 70s or 80s, and they involved one 15-year-old teenager and one 17-year-old teenager. I'm not aware about literature about the medical outcomes of these donations.
I don't think they've been followed up, to be honest.
Hello. In Bristol, we've actually got a lower age limit for live donation of 30 years. And that was
13.
30.
Yeah, 30. just to be sure.
Just to be sure. And that was absolutely set in stone about 18 months ago, a thick black line. I think that line's now a bit more grey, a bit more fuzzy. But I think that's probably at the other end of the spectrum. So I think in Bristol, we'd completely disagree with using a child. But we're working more towards maybe something like 25, somewhere in the middle where we all do feel comfortable about the perceived long-term risks to that individual.
Okay, so and on long-term risks, Steve, you mentioned the Doris Segev paper, saying that there was an increased risk from living donation, but what you didn't mention was the second half of that sentence, which said that the absolute risks are small, so the relative risks are high of renal failure if you compare living donors with non-donors, but the absolute risk is still very, very small. Anyone else like to make a point? Any other thoughts? Yes.
Scenario, but we have a lot of young parents. So we have parents under the age of 25 that are up for living donation. I don't know where that sits.
I mean, I think that's a very interesting point. And some would say if you made the decision, or maybe not the decision, but you've done the act to fall pregnant in the first place, then you have the maturity to understand what you're doing with your body. At that point, that actually a few years later in your 20s you have, but obviously that is a debatable point, I think. But yes, no, we also have, and we also have very young grandparents. I mean, with Anita, we've had grandparents in the very early 40s that have come forward that we're going, I mean, I can't make comments now. You have to find out if they really are the mum and dad or the grandmother, the grandfather, the stepfather, stepmother. You can't make assumptions when people enter the clinic room anymore.
Thanks. So one of the things that we haven't really touched on with either speaker is what are the risks of not donating to the individual who doesn't donate? We see this with adults when we say to adults, you're not fit for donation. Hannah, I don't know, you're hiding in the corner. I don't know if you've got any comments about that.
So a lot of the outcomes that we found psychologically in the living donor group are that actually things don't change a huge amount after donation in terms of benefit. But one area that we're looking at now is to see whether or not actually if you don't donate, whether that's actually worse for you than donating in the first place. I don't know if there are many coordinators in the room, but we're currently recruiting for the BOUND study, which is looking at this in quite a lot of detail, and also the altruistic donor group. And often some of our altruistic donors want to donate specifically to children because they think they're going to get more out of it, or they feel that the benefit is going to be greater both for them and for the recipient. So it'd be interesting to see what you think.
So I can recall an 81-year-old who had worked as a nurse overseas most of her life, had donated blood, donated bone marrow, I think. And she said to me, if I drop dead in the supermarket next week, you might consider using one of my kidneys, both of my kidneys, but you won't take one of my kidneys while I'm alive. We turned her down because she had various risk factors, and she wrote a long letter saying how much that had affected her. So that's at one level, one extreme. What about someone who is 17? What effect might that have on them if they're unable to relate and they watch their sibling die?
So to answer that question, the first thing is you're not going to discuss this with them unless they're actually voluntarily coming forward as a donor. So in other words, you're talking about people who want to do it. We're talking about the fact that members of the family are trying to put additional pressure on family members. And the other thing is that we instituted a few years ago, not only do we have the National Living Donor Kidney Sharing Scheme, so any friends and families, we've had gardeners coming forward as potential living donors. There are other avenues to look in living donation. In addition, if you had your child that was going to die, Nizam, next week, we've got the clinically urgent scheme where you would get a fully mismatched kidney within a week. So there are other ways of getting organs. We don't need to use children as donors.
Right.
You also have the social media, of course, and you know the case from Great Ormond Street that had an advertisement on Facebook and had some 25 donors come forward, and we chose a 24-year-old female to donate in the end through the process of elimination. So yes, you're right. There's other ways.
Okay, so thank you. So I think we're going to start to wrap up now. So Kristof, I'd like you to give 5 minutes maximum, just rebutting some of those points. And then Steve, and then we're going to vote again.
All parts of the discussion, but I think maybe 2 points to consider. First of all, I agree with the fact that usually there are alternatives. Nevertheless, you could think of situations where not allowing a young person or a minor to donate may be more helpful, I think, than for an alternative. Think, for instance, of a young 17-year-old teenage parent. If you refuse a young parent to donate to a child, it's a very stressful experience for parents, because parents have this kind of, I have to do this for my child. So they feel this kind of moral internal obligation. So I don't see why you would refuse a young parent in the same situation. So that may be, for me, an exceptional circumstances where you could allow minors to be donors. I also think that I agree with you that the definition of a child is very problematic at this point. And law is very clear cut on this. So you have the adults and you have the minors. Whereas adults can do everything. Legally speaking, adults from the age of 18, you can become a non-directed donor. Whereas there's a big difference in terms of psychological issues with non-directed donation versus donating in families. So usually, I think we have for young recipients, you have special programs that give more supervision to them, more counseling to them, for instance, for adherence problems and so on. So maybe we could think of a similar issue with regard to the young donor population. So get special programs that give them more dedication, that give them a longer screening, that give them more counseling to make sure it's a real and it's a good decision. And that period could extend from, I think, the age of probably 15, 16 up to the age of 25, 26, so including as well older adolescents, as well as younger adults as well. So rather than having the clear-cut age fix of 18, where lower than 18 nothing is allowed, and older than 18 everything is legally allowed, I think you could go for a more flexible solution there. I also think that use the non-competent minor, so the 12-year-old, probably they should not be allowed, because you have to be really competent to make the decision. I don't know my all is able to make the decision. I don't agree with that. I think it's probably for all living donations that you involve the family. So I think I would opt more for this flexible approach. Maybe one thing I'd like to add is the issue we discussed. Well, young and the risk of family pressure, and so the risk that the parents will enforce their decision to become donor. But if you look at the young donor population, you may also reverse issue, namely that young parents, sibling of 20 years old, sincerely wants to be the living donor. He knows, he has read about the risk, he's made a good decision, but he's not allowed because the parents don't want the sibling to be the donor. And they think they are parents of a child with a chronic disease and say they should be the donors because it's their duty as a parent. And in my potential donor decision making. Parents.
Kristof, sorry, we're losing you intermittently. We're losing you intermittently. I think we have a bandwidth problem.
Okay.
Can you just repeat what you just said?
I think next to you have on the one hand, you have the risk of parents forcing children to become live donors, but you also have the risk of parents forcing young people not to become donors because they don't give them information, they don't include them in the decision-making process because they think they should be the living donors themselves.
Okay. Okay, thank you.
Okay.
Steve.
Okay, while we do the technology and we transfer back across, you remember when we started this debate, there was a beautiful sky out there. Have you seen what's happened now? It's gone grey, clouds have descended. I don't know if you're all religious, but maybe God is crying. It seems to be really significant now. So yes, so we've got to look after our children. I think that's the bottom line. I just wanted to touch on what it means to be a donor. And Anita said it quite beautifully, that there are lots of negative aspects to living donation which comes out in the months and the years afterwards that I think really have a lot to play. And even when we have parents who are in their 40s and 50s that donate, that bond can sometimes change, and not always necessarily for the better. You're not looking after my kidney. Whose kidney? Who has the ownership of that kidney? And I just touch upon a few things here that come up, that donors have expressed their fear and vulnerability after donating, their sense of loss, of physical loss, but also depression and guilt have come into play. And you can see here as well that the relationship isn't always strengthened. There can be negative, and there's lots of donor-recipient pairs whose relationship has actually been lost because of going through living donation. And the process to be a living donor is a long, stepwise process of getting multiple investigations, seeing doctors and nurses, radiologists, radiographers, having tests. It is a big endurement for a 12-year-old child to undertake, to do this for their sibling. It's very, very different in being a bone marrow donor. So I think we have to be advocates for children, at least until the child grows up, to become an adult, to make that decision themselves. There are other transplant options. We don't have to use the child's sibling to be a living donor. We have to safeguard children at all times. We've all signed up to that working in pediatrics. Yes, we have dialysis, and yes, sometimes there can be problems in getting dialysis, but as I said, there's the clinically urgent scheme. There is altruistic donors, there's social media, there's paired exchange schemes, and there's also ABO and HLA incompatible transplantation, where that possibly can happen. And I think as Nigel Heaton was touching on, what age actually predicts maturity. And there is a complete difference in Scotland and England and Wales, the Gillick and Fraser competence, what the Human Tissue Authority deem as different. Even the BTS Ethics Committee is given. But very often, as Kristof says, you actually need to get court approval. And that's, again, a big undertaking for a family who are already very much stressed. So I think mankind owes to the child the best it has to give. And children being living donors is not that case. So I know that it's been tough. Nothing that's worthwhile is ever easy, remember that. But I think we know the outcome.
That's quite a shocking image. All right, thanks to both of our speakers.